asking me to come and speak, and I'm going to address this piece of legislation. This is the bill that's arrived with us from the Commons, called the Terminally Ill Adults End of Life Bill, and we've set up a select committee, which is a very short select committee to take evidence, and I've got the privilege of being on this committee. So some of the things I'm going to refer to are things that are the diagnosis, prognosis, treatment available. If you're in an area where some treatments aren't available, well, you know, if you live a long way away from some aspects of treatment, and then it says appropriate palliative care. The interesting thing later on in the bill is that it talks about accessible, the palliative care that is available. And in the discussion in the Commons, Kit Malthouse was clear that you must not ask a patient, why do you want to die, which I have a big problem with, because every patient who says I want to die, in good medical practice, you explore what the reasons are behind it. Why are they saying that? What is wrong? What's going on? Unless you undertake that diagnostic step of exploring and exploring and exploring, you can't be a good diagnostician, let alone manage a patient well. And the bill came to us with quite a lot of amendments that were never debated. I'm not going to go into the mechanisms of the different chambers and how we work, other than that in the Lords, because we're self-regulated, we don't have a guillotine, and what happens in the Commons is that there is a guillotine all the time. So I think the first thing you have to say is what's the problem we're trying to solve with this legislation. More one looks at the reasons behind why people seek an assisted death in the different countries around the world are existential, rather than actually being pain or suffering, although the bill's being sold on the back of pain and suffering, but they don't feature at all. Neither of those words appear in this bill. There is an issue around suicidality and how we behave towards a patient who presents with suicidal ideation. And I think we're going to have two different approaches. We're going to have people where we have suicide prevention policies, and we have the others where we're going to have suicide facilitation, potential prognosis, I'll come on to that in a minute, but who appear suicidal, is saying that they wish to die, which is quite common in palliative care. Then do we work on our suicide prevention approaches, or do we facilitate the suicide? And that's going in two different directions. One of the other problems that we've got is that actually care is often inadequate. Specialist palliative care is patchy. Wales was doing really well, but the developments haven't kept pace with the expenditure in other areas. And around parts of the UK, there are basically black holes. There just is really an absence of specialist palliative care. And then the question is, how will errors, the way this is written, how will errors with diagnosis, errors, mismanagement perhaps, that's happening, difficulty with prognosis and so on, be picked up? And I think there is a fundamental question, and that is processes. The guidelines that have to be written, the way the bill is written at the moment, do not have to be complete before the bill comes into commencement at 4 years. So it could start at 4 years without all the guidelines being worked out. What about the numbers that we can expect? Well, this is the data from the different countries. Oregon is a small population and is the blue line down the bottom, which is assisted suicide only, but that's where the patient has the drugs themselves at home, and they take them when they want to, and the doctor isn't there or involved. Canada is the red line, which is going up rapidly. I think New Zealand I haven't got on the chart, but the rise there seems to be pretty steep as well, steeper than the Netherlands, which is orange, or Belgium, which is the black line. The Belgian one, we do know that only about 50% of them are actually reported now.
so that line is probably much higher. The impact assessment on the bill suggested that by year 10, we would have just over 4,500 assisted suicides in the UK. But if we look at the rates from other places, I think it will probably be nearer 7,000 based on Oregon, which was that low blue line on the previous slide. But euthanasia as well, which the minute that you introduce the ability for the doctor to inject, that becomes the chosen route to death, and the numbers will probably go up to somewhere around about 30,000 a year plus. So that's quite high. You'll hear a lot about all the other countries that have changed the law. There are actually a lot of places that have looked at it and not gone down this road. The Danish government have decided against going down this road, having had their commission look at it, because they felt that euthanasia was in conflict with palliative care, and that it would become an expectation aimed at groups in society. Interestingly, the group in Canada, the Civil Liberties Association, campaigned really hard for their law to change, but they now see coercion by doctors of people who are disabled, people on lower incomes opting for medical aid in dying, which is what MAID is, for social reasons, because they don't have money, and they are beginning to feel very uncomfortable with the fact they feel that it is far too easy. The no detriment clause doesn't apply to the other people there. So what about the receptionist? What about the cleaning staff? What about care assistants? Because they're not registered in England. I know care assistants are in Wales, but they're not in England, and they wouldn't be covered by the no detriment clause. And there is an issue around hospices and care homes as well, because care homes have told us that they did not feel at all consulted. That's been in the evidence we've taken. There was originally a High Court judge to be the final arbiter, but now it is a panel. And the panel, I think there is a concern that this could be a tick box exercise, because they come after the two doctors it's just the doctor on their own, and it's effectively in secret behind closed doors, and the two then report in to the panel. But the panel have no powers to summon witnesses. They have no ability to take evidence from other people who may know the patient, like nursing staff, care assistants who've been into the home and so on. And there is no appeal mechanism against an approval. There is only an appeal against a refusal by the panel. So a care assistant, for instance, who is worried about coercion going on in the home and who's overheard difficult conversations, there is no way that that seems to be able to be fed into the system. And as Lord Justice Mumby has said, it's little more than a rubber stamp, providing a veneer of judicial approbation, and that it's fundamentally unacceptable. A thing that I think is quite worrying is the family don't have to be informed, and the family don't have to know about this. So sadly, we keep on, not all families are loving families. It would be great if they all were, but I've certainly been taken in by families where they actually were really disappointed that somebody didn't die before a fixed term life insurance policy ran out. I've been taken in by the new spouse who appeared to be really loving, and then got the will changed to leave everything to him. Sadly, that kind of thing goes on, and we know that coercive control and coercion is quite common. Jamila Hussain, who's in Bradford, has highlighted the problems of abuse and coercion, particularly abuse of women within some communities, and the increasing fear amongst communities of accessing medical help of any sort in case they feel that they're going to have their life shortened. The training to detect, the doctors to detect coercion in the training programs that there are, for instance, in Australia, are very, very short. I think it's 5 minutes in Victoria in the whole training programme. And it really worries me because I know that we are really bad at detecting domestic abuse and coercive control. And there isn't an explicit ban on encouraging or undue manipulation, although if pressure is discovered, that goes along with a life sentence. Life imprisonment is the sentence in here on pressure. I can say a bit more about that later. The sort of case that concerns, I think, is somebody like Peter Farker. I don't know how many of you have seen the TV programme, The Sixth Commandment. Yes, some people are nodding, which I found really scary actually to see, because nobody had realised about the manipulation of this man by his husband, and what was going on, and actually he turned out to then go on to trying to kill somebody else as well. But it would have been undetected if he hadn't gone on to try and kill another person. What are the drugs used? Well, there's been no research whatsoever to evaluate how the different drugs work in these lethal mixtures. They're fixed doses. So if we look at what has been used previously in Oregon, it used to be a barbiturate, but that is not available anymore. So they've experimented with 4 other different drug mixtures, which are now mixtures of diazepam, digoxin with a little bit of morphine, not nearly enough to end your life, and amitriptyline, but it's about 100 tablets in total. It does have a complication rate running at about 6.9% from the data that we can get hold of, and 9 people have reawakened in Oregon and 7 people have reawakened in California. The bill is not clear about what you do if you're the doctor who's there and the person's beginning to lighten, because it has to be the patient themselves that does something, nor is it clear about what you do if other complications arise. In other countries where there's an intravenous use, then usually a short-acting anaesthetic with a paralysing agent, there's been no study whatsoever to see whether the person regains consciousness before they die. It's a bit like with the women who were conscious during caesarean sections, where the anaesthetic agent wore off, but the woman was fully aware, but of course because she couldn't move a muscle, she couldn't trigger to alert people, but she was being ventilated, so she was oxygenated. Whereas here, of course, if you can't breathe and you can't move a muscle, then you die of asphyxia. It talks about a device, but we don't know what the device is, because attempts to come up with a device other than a computerized system, which was developed by Nietzsche in Australia, I've not come across, but somebody may know of what they plan to use. So the assessment, first of all, there's a conversation, then there's an assessment, and that has to happen as soon as reasonably practicable. I think there is a difficulty if this is part of healthcare, then what happens to your other patients, and where's the prioritisation with other patients? And you have to discuss any available palliative care. So that's different to appropriate palliative care, because I said there are black holes, and the family may know nothing about it at all. It relies on the Mental Capacity Act and the 5 principles of the Mental Capacity Act, which would mean that you have to presume the person has capacity, support them in their decision, and it is only when that is no longer possible that you would then go into the role of assessment. But of course you can't be taking a best interest decision on behalf of the person in this situation. So some of us have got amendments down, oops, it's not me, no, amendments down to try to put a better assessment of capacity into them. As I said, for a 6-month prognosis, you've got a 48% chance of being right. So really that's quite difficult. And your chance of being right gets less the further away you are. If you're within 2 or 3 days of death, you've got a pretty good chance of being right. but not otherwise. Conditions whose progress can be controlled, such as diabetes or post-transplant or cystic fibrosis, may turn out to qualify if other criteria are met. And the whole issue of anorexia nervosa has come up. There were amendments put down that were rejected. The amendment that went in now does seem to be against voluntary stopping of eating and drinking, but that's different to anorexia nervosa, which is a mental health condition. So there will need to be further amendments to the bill, because otherwise we'll find, I think, that anorexia nervosa will become included. What about the conscience? The BMA wanted doctors to have to opt in to be involved. The bill actually talks about doctors opting out much more than opting in. And there is a clause to say that if you do not want to participate, it must be without detriment. So you can't lose your job by refusing to participate. In some parts of the world, doctors have lost their jobs if they have said they won't have anything to do with this. But I think that is protected here. At the time the bill went through in Canada, people were told that what was happening in the Netherlands couldn't happen there. And there's a claim that nearly everybody has palliative care, but actually they have remarkably little specialist palliative care in Canada. And we know that the increase in palliative care in Canada, although it has gone up by 6%, the increase in medical aid and dying deaths has gone up by 550%. And the budget for palliative care has been in part